Hi, everyone. You can see people coming in now. So I will get us started. Welcome to the Renegade Research Clinicians Roundtable. I'm Tess, founder of our organization. We're a patient and caregiver-led, decentralized 501c3 nonprofit focused on complex chronic illnesses like ME/CFS and long COVID. We have three areas of focus: research that's agile and patient-centered, education to increase the number of clinicians treating us, and community where we focus on practical advocacy around barriers to care. We have a wonderful team of volunteers who move the wheels of our organization, and most of us have a personal interest in advancing research and care of these conditions. You can learn more about us and sign up for our newsletter to be notified of future events on our website, renegade-research.org. Our work is funded by grants and donations of all sizes from the community. We will share a link to donate in the chat for everyone who would like to contribute. I'll pass it off to Ellie to introduce our guests and speakers today.
Thank you, Tess. My name is Ellie Brocious. I've had ME/CFS for over 30 years. I am a volunteer with Renegade Research in both the Remission Biome Project and also the Adverse Events to Anesthesia Survey Project. I was in Dr. Rowe's very early study on tilt-table tests in ME/CFS for adults, and the findings there and the treatments have helped me tremendously over the years, and his continued publishing of findings and treatments helps me to this day. And part of my mission is to help people understand what those findings are and to apply them in their lives. Sometimes we can know about something for years, but it really doesn't sink in how to use it practically in our lives. And I'm so grateful to Dr. Azola and Dr. Rowe for coming and talking about them more today. We have two guest panelists with us today, Bridget Collins and Denise LM from ME Action Maryland, who worked with Dr. Rowe on a 4-part series on pediatric onset ME/CFS. So if you need to know more about that, please find those parts 1, 2, 3 on YouTube already. And they're working on part 4 on thoracic outlet to be coming out soon. Dr. Rowe is a professor of pediatrics, and Dr. Azola is an assistant professor of physical medicine and rehabilitation. They're both from the ME/CFS and similar disorder program at Johns Hopkins. They are both renegades in this field because anybody who gets into this field from a professional standpoint must have renegade energy. So we are grateful to them for that, and please educate and validate us some more today. Everybody, today is all about questions and answers, so please start popping your questions into the Q&A. I will start with a question about hand grip strength, because I started doing a thoracic outlet exercises a little bit more intensely after last week's seminar, or February 1st, part 1. And I have noticed my hand grip strength has increased using a hand mover. Do you use that in your research, and is it useful for people to have at home to monitor?
So I'll take a stab at that. Ellie, thanks for having us today again. We have not used that very much. It really emerged from some work being done in adults, and in the UK, I think was the first paper on it. My colleagues in the Netherlands, Linda van Kampen and Frans Visser, had assessed it, and they had not found the same results, that hand grip strength was a marker for ME/CFS. I think there haven't been enough formal studies to be entirely sure who's right about that. We have not incorporated it into the assessment of the adolescent patients and the young adults, mainly because we do a lot more extensive testing at baseline of their range of motion and what we call neurodynamic dysfunction, like are the nerves gliding properly in the limbs and the spine, and those are things that our physical therapists can help patients with using very gentle manual hands-on techniques rather than exercise-based physical therapy. And one of the consequences of that, as people get better alignment, more efficient use of their muscles, is they're going to have improvements in strength. So it's not surprising that you've seen what you've seen already. We think that strength will improve if nerves are not being hung up in different areas, especially through the muscles of the thoracic outlets and thoracic outlet area and elsewhere. Alba, have you found it helpful in the long COVID adults?
No, I have not used it on that regard. Actually, well, Agustina Casamiento, who's a postdoc that I worked with closely, she studies fatigue and fatigue economics. And she did her study with the long COVID patients for clinic, used hand grip as the fatiguing trigger. And
Yeah.
And that was kind of interesting. There was no difference between normals or healthy controls and the long COVID patients in their ability to generate the actual strength, but it's only it was a short amount of time. I'm not super familiar with the data on older adults and aging, but I know that is a commonly utilized thing on the aging population as well. Yeah.
The most surprising thing that happened to me was it was part of my neuropsych test in 1992 for ME/CFS, and it showed my non-dominant hand was stronger. And the hypothesis or research then, the thinking then was that the dominant hand was exhausted because it was doing everything. It was in PEM, and that's why there was a surprise finding of the non-dominant hand being stronger. I don't know if that thinking
or it
has
could be
continued.
like POS too, like yeah.
Exactly. Exactly.
It could have been something like yeah.
I always wondered
yeah.
if it with the mapping of the person on the brain, the homunculus, and the hand being way up high and out to the edge, whether it's a sort of a muscle group area that is out in the periphery. And so if there's small vessel issues and so on, would that pick it up? Would that be one of the most sensitive things to pick it up? But no data to support that concept.
Not sure. One other thing that may be relevant to the discussion of hand and arm symptoms is that, especially in the Ehlers-Danlos population, it's clear that you can get interference with hand and wrist function by compression of the nerves as they're going through the scalene muscles in the neck. But there's a Dr. Erickson out in Seattle who spoke at last summer's EDS conference, who identified several areas where the nerves that affect hand function can have fibrous bands across them, especially in the EDS population. So he will do procedures to release or decompress these several areas at one time in the arm, and strength improves dramatically. So I think a key thing is making sure you've got the right diagnosis. And if somebody had one of these nerve compression problems, they probably aren't going to improve with the hand grip device.
So I'll just chime in on that is exactly my experience, what you just described. I was in physical therapy for a while, had muscle wasting in my right arm and my hand, and they thought I just needed strength training, that nothing really seemed to help much. And then I found but it wouldn't be consistent. So I'd have strength some days, but not other days. And then I found a few motions that I could do just myself, and I couldn't raise my arm. I just couldn't raise it, not straight up. I could do my left just fine, but not my right. But if I had somebody help me raise it, to them, it felt like I was fighting them and refusing to lift my arm and pushing down. But I was trying really, really hard to get it up. And then when I finally did, then I could feel the release. I could feel the nerve kind of like almost the feeling almost of like blood flow to the nerve finally. And then after that, I could raise my arm just fine. I have also had a similar thing in my right leg, and I had muscle wasting in my right glute. And then when I'd have somebody else help me lift my leg, then again, the same thing. They thought I was fighting them, and I'd be like, no, I'm trying really, really hard. I'm working. And then it would then release, and then I could just use it like normal. And so that the idea of like adhesions or something holding onto the nerve and binding it makes perfect sense for me, because it would almost always after some sort of like inflamed aspect, and then having that, and it was separate from like thoracic outlet symptoms necessarily for me. That was just more of like I'd raise my arms and my arm would be fatigued for the day. This other one was just, it was like a constant until I had somebody help me mechanically move my arm. It's not something I could do on my own. My muscles were not sufficient for it. I couldn't fight past it. But then after that, then my strength in my hand would come back. It's like instantly, like it was right then. So it was like the idea, like what you said, Dr. Rowe, that it fits exactly with what I had. So
It's interesting. We've been working on this issue for really 25 years. I don't think it's had the traction it deserves in the rest of the MECFS research community. And maybe because these concepts are a little bit unfamiliar to physicians. They're much more familiar to physical therapists. But we were working with a really superb manual therapist, Rick Violand, and Rick has taught us a lot about paying attention to these areas of restricted range of motion, even in people who have ligamentous hypermobility. They probably get into more trouble. It seems paradoxical, but they probably have so much movement in their ligaments that they get out of alignment more readily. But for example, some of our patients cannot get their arm much further down than this when we're testing range of motion. And what the physical therapists do, it doesn't always require surgery, obviously. They bring the person back to the point where their arm is not under tension. And they do these gentle oscillation maneuvers called neural mobilization. And then after a while, that arm can move down more. And it may be that, as Rochelle said earlier, there's been some kind of adhesion around the epineurium, the outer coating of the nerve, such that the nerve just doesn't move and glide the way it should. So a lot of our current research is looking at replicating the work that we published in 2014 on these movement restrictions. And this year, Dr. Azola and I published a paper on our experience with thoracic outlet syndrome, where we simply took all of the patients we saw over a 4-year period and said, who's having trouble with anything that involves arms overhead postures? And those patients then had a 3-minute test where they sat like this, opening and closing their hands. This is called an elevated arm stress test or a Roos test. We did it only for a minute in our patients, and it was striking how many had symptoms in their arms. So arm fatigue, numbness and tingling, shoulder discomfort, headaches, that kind of thing. And what has not been published in the thoracic outlet syndrome literature, they got systemic symptoms from that activity: fatigue, lightheadedness, feeling hot. So this could turn out to be another test that's very easily incorporated into regular clinical practice, and then leads to referrals for physical therapy as the treatment of these areas of nerve entrapment in this part of the body. And occasional patients need surgery. And yesterday we had a follow-up visit with one of the kids who's a student at George Washington University. She was having terrible grip strength problems, lots of arm pain, had radiographic or ultrasound evidence of compression of things in the brachial plexus and in the thoracic outlet. She had her first rib removed on the one side, and the difference between right and left now on the side that has been treated is dramatic. So this is a young woman who's really keen to have the other side operated on to really free up the tissues in the thoracic outlet. So it's an area we're actively studying in our current cohort study, so we'll have more prospective data. But I think just another example of the abnormalities that are there on the examination that nobody used to look at. All right, have we got more questions?
Do you have a specific diagnosis code you use for the thoracic outlet syndrome besides the general one that's 65.60 G54.0? Does that cover everything, and does insurance bulk at that? You use it with CFS or?
Yeah, we will use I think that's the one that's generated by our medical records system. And it doesn't seem to create any problems for patients getting reimbursed for testing or visits. So I think that should suffice.
Because we have to, take it to our doctors and teach them about that code, so I
Yeah.
want to make sure I use the right one when I bring it up.
Just double checking, the one that is generated in our system is G54.0. Yeah, I think it's.
Right.
And keep in mind that there are different types of thoracic outlet syndrome. By far, the most common one is when the nerves are involved. So neurogenic thoracic outlet syndrome, it's called. You can get compression of veins and arteries. Those are maybe less than 5% of all forms of thoracic outlet syndrome, but they show up more with a kind of purplish swollen limb or real color changes. So those need to be addressed and dealt with by a vascular surgeon. Most of the neurogenic types are going to respond to physical therapy maneuvers and more gentle techniques. But if things are not improving, the surgeons will often try Botox to the scalene muscles. They inject Botox into the muscles towards the back of the neck. That allows these muscles that sometimes are quite hypertrophied in the setting of thoracic outlet syndrome to sort of shrink in size, allowing the nerves that are going through those muscles to be less compressed. And so if you get really nice improvements with Botox, but it wears off after 3 months and keeps coming back, that might be an indication that surgery is in your future.
Who does the injections? What kind of doctor does those?
So it's usually anesthesia pain management people or interventional radiologists. Sometimes they'll precede it, Ellie, with like a lidocaine or some kind of local anesthetic block to see if you get any improvement over the course of the next couple of hours. And then if that's positive, that helps justify the use of Botox to the insurance companies.
There's some barriers with justifying the Botox injection. So it's not all insurances are approving that, but some do.
But you definitely want a positive Roos test documented, right, before you even try that.
I think that also the ultrasound of so they do the thoracic outlet ultrasound, where they do the ultrasound with the hand and abduction at different angles, and they look for changes in flow of the blood and evidence of compression of the structures of the neurovascular bundle. And then that's also like another, just, kind of additional beef to justifying the injections.
Yeah, as Dr. Azola mentioned, it's very hard to tell that the nerves are being compressed, but you can infer that they're being compressed in the thoracic outlet if, when the arm goes to the side, the vein collapses, and so you get less flow velocity through that, or the artery is narrowed and it's going to act like a garden hose with a thumb over the end of it. You're going to have an increase in the flow velocity when it gets narrowed. And that can, as Dr. Azola mentioned, that's often used to justify the next steps.
And that you ask a primary care for an ultrasound of the brachial plexus. Is that what you asked for?
We have an order in our system. We have a vascular ultrasound lab. They're particularly good at this, and we ask for a Doppler ultrasound examination of the thoracic outlet.
Yeah. I wonder if that's a specific code for the procedure, like a specific ICD code.
Yeah, I don't know. I
We're
think with
lucky
the
to have.
As with a lot of diagnostic tests, it's really important to get them done by people who do them all the time. So you don't want to have, you just need somebody experienced who knows what they're looking for, knows how to position the ultrasound probe, that sort of thing.
Y'all mentioned this last year and described it well, and I knew it was involved for me, but my only thought was I do not want to hold my arms up for 3 minutes, and
Right.
so I've been not dealing with it. I go to PT. I have a good manual therapist here in Northern Virginia, Ty Heitman, and every time I come out of there, I feel 100 times better. It doesn't last very long, but that's what he says. No matter if I say I have back pain, he says it doesn't matter. We have to work on your thoracic outlet. He can tell, and he does, and I feel better. But it's taken me a year now to really want to work on it, because if it involves having to show this functional problem and get temporarily worse, I'm a little hesitant, but more ready now. Thank you.
We have a couple of questions popping up in the Q&A, so I can bring up the first person to have on there, and Chris, what is it? Trying to see my screen here, Blitten. If you are ready, I'm going to bring you up, and you can talk whenever you're ready to ask your questions. And if you don't want to, I can ask them for you, but I can, you're available. You're allowed to speak. There you go.
Yeah, I was wondering if there's been any progress on figuring out what causes post-exertional malaise, and like what the mechanisms are, and if there are any treatments that are new that are aside from pacing. Thank you.
I'll let Dr. Azola tackle that one first, because that's a focus of her research. But before I hand it over to her, I will say that one of the things that we found to be most helpful for addressing post-exertional malaise is not a direct treatment of that problem. It is to really get after the orthostatic intolerance. And if you can get good blood flow to the brain, PEM seems to fade away. So the treatment for us of most of the symptoms of ME/CFS and long COVID involves optimizing blood flow to the brain, improving the orthostatic intolerance. It's not quite that simple in everybody, but that's our first main step. And then anything else that contributes to some sort of physiologic disturbance that prevents blood from getting up to the heart and brain. So that might involve things like improving the vascular venous compression problems like pelvic congestion syndrome and May-Thurner, and the thoracic outlet syndrome. It might involve work on mast cells that lead to excessive histamine release and excessive blood pooling in the limbs. So the way of getting to this issue of improving blood flow to the brain might be varied, but you have to get after that in order to get rid of some of the PEM. We've seen PEM after a simple tilt test that you can have a week's worth of symptoms just from being on a tilt table that involves very little actual physical activity.
Yeah, I mean, the one that's more fascinating to me is the cognitive causing kind of full-blown PEM symptoms similarly to the physical trigger, right? So not that we know anything concrete yet. I mean, we have plenty of evidence of changes to biomarkers regarding the autonomic nervous system, biomarkers of inflammation that elevate, with a delay after activity. We have now evidence of changes in the muscle from Robert's work. So there's some clues, but we don't have the final answer. And yes, I think the fatigue is just not the fatigue, is all of the things that are contributing to it and that result in that narrower window or narrower energy envelope that then leads to the PEM. So expanding that envelope by tackling the things that are, I've been calling them the energy leaks. A lot of energy leaks from standing and having that sympathoadrenal response. That's very energy consuming. Cognitive, emotional stress. So there's many ways to tackle and to try to expand that mast cell activation syndrome as well. So yes, final answer is we don't have the exact answer, but clinically we focus on tackling all the things that are draining energy from the narrow energy envelope to try to expand it and help have less PEM symptoms given the amount of activity. Yeah.
Do
you
you
know
see
if-
any,
Oh, go ahead.
do you see any improvements with stimulants? There are a lot of anecdotes in the dysautonomia forums. Obviously, they tackle the ANS, and as with everything with ME/CFS, some patients do respond really well and others don't. But is this something that you have seen in your practice at all?
Yeah, one of the drugs that we use in adolescents and young adults, probably the most commonly used class, is the stimulant class. And in part, it's because they act as very good vasoconstrictors. So if the problem when you're upright is that you've got too much blood pooling in your vessels of the lower half of the body, causing them to constrict and push that blood back up to the heart and brain is going to lead to benefit. Not everybody tolerates the stimulants. Some people get too much insomnia or reduction in appetite, or they just feel too agitated. But they can be a very helpful class of medications. The advantage of stimulants over a non-stimulant vasoconstrictor like midodrine, especially if you've got adolescents who are going to school, is that they only need one dose in the morning of a long-acting stimulant, and that lasts them till the late afternoon, whereas midodrine has a very short therapeutic span of just 4 hours. And so when we're starting that on a school child, we need to send in a note to the nurse every couple of days when we adjust the dose. It really is quite cumbersome, and it's tough for people to comply with a regimen that involves 3 or 4 doses of a medication daily. But we find that the stimulants are really often quite helpful, especially I think in the group that has laxity of their connective tissues and joint hypermobility, because if their ligaments are loose and their skin is stretchy, the wall of their blood vessel is likely to be stretchier when they've got that column of blood going down by gravitational pooling. And so if you can counteract that with a stimulant or midodrine, you're usually going to do better. I think one of the misconceptions about stimulants is that they create some kind of false energy and then lead to worse PEM. We just don't see that. We find that if the person's energy is better, it's because they're getting more blood flow to the brain. Yeah, so I would not worry too much about that. I think as energy improves with a given medication, you got to be careful that you're not doubling and tripling the amount of activity that you have in a day. You have to still work up gradually, or else that will create some PEM. I don't know if you have any further thoughts on that, Doctor.
I have seen a few patients at times with kind of not false energy, but mainly like cognitive exertion. Like I've had a few patients that take stimulants or higher dose stimulants, and all of a sudden they, run themselves into PEM because of activity. I don't think it's like the most common thing as people think. Like it's not as common as perhaps the perception is, but I've seen it happen in some of my patients, mostly with cognitive exertion, which sometimes they have to be more vigilant about. But yeah, I mean, I used to be kind of more hesitant too, but since I've been working with Dr. Rowe, I've been kind of utilizing them more because I can tell that there's an improvement, beyond the brain fog with the orthostatic issues, and certainly are well tolerated, and usually you don't need high doses. Yeah.
When you were talking about the PEM with cognitive load as well as physical load, have you seen any data around that happen to capture some lab markers or other markers that were consistent to say to show that? So is there a difference between exhaustion within the skeletal muscle and what shows up, and exhaustion within the brain? Intuitively, it seems like there may well not be, but just wondering if you've seen anything around that.
We are in the middle of reviewing the literature on PEM, and we have a small army of trainees, kind of screening those, and we're really kind of trying to get a sense of what's out there. I think by and large, the studies that look at markers in the blood are looking at physical exertion, but there's other studies I know will measure it in terms of like patient-reported outcomes after things like, I think Dr. Rowe, you have some, I'm not sure if it's published, but you have some data on, for example, straight leg raise and that triggering post-exertional malaise symptoms. I have one of the studies that I'm involved in. It's neurocognitive sequelae in long COVID patients, and they have a pretty strong battery of cognitive tests, and we do the FUNCAP 27 to measure what's happening on the subsequent days. So we do 3 points after the day of the study. Mm-hmm. So we're looking into trying to understand, how that exertion also can cause PEM. So hopefully more to come.
I'm not aware of any biomarker studies. I did want to just mention about the stimulants, that's one of the areas where there are several small randomized trials of the use of stimulants for both overall symptoms and cognitive symptoms in ME/CFS. I think there are about 5 or 6 that have been done. So that often is not included in people's systematic reviews of what works for ME/CFS, but the papers are out there.
And sometimes I find patients that have POTS and ADD, and they were on stimulant. Sometimes their primary care will remove the stimulant, thinking that it could make the POTS worse, but it's the other way around. So that's kind of an interesting thing that I've seen on my patients with that.
Yeah, people often are apprehensive about the stimulants increasing the heart rate, but if they're working by causing better vasoconstriction, the resting heart rate actually comes down a bit.
So we have some questions in the chat that from the panelists that I'll go ahead and bring up for panelists that can't come up right now. Do you think compressions are present prior to triggers and the compression remains unchanged but becomes symptomatic due to lack of compensation function in other body systems, like, for example, onset of POTS? Or is the compression downstream of the trigger, like MCAS, leading to a connective tissue laxity?
It probably goes both ways, but I think when we talk to our physical therapy colleagues, they often point to the fact that you can get some what's called adverse neural tension or adverse neurodynamic function, tightness in the nervous system, for lack of a better term, from the results of just everyday life, wear and tear, injuries, and that kind of thing. And that may set you up to not have as much ability to compensate for a new stressor, like an EBV infection or something else. So oftentimes we're finding that, and Dr. Azola can talk about the long COVID experience, but in the ME/CFS patients, there's something smoldering along long before they get an infection. And in the pandemic, a lot of people were just focused on the virus not on the host that it was affecting. And the host factors are really important in the long COVID research, because many of these things that we found in ME/CFS are also present in the long COVID patients. So this notion of running out of the ability to compensate for a new stressor is a physical problem as well.
Totally, 100% agree with that. I feel like there should be more, should highlight more host factors in the research of long COVID. I think that it's been something that has not been as present as it should. Yeah.
So then I'll pull another question from our panelist chat, and then I'll go back to the Q&A. So another one in the panelist chat is, do you think compressions are present prior to, or wait, that's one I just did. This next one right here. Do you recognize different types of blood pooling in the extremities? If so, how do they differ, and what might those differences mean? For example, sluggish perfusion versus blushing versus swelling versus vascular, etc., etc.
I am not sure we've really looked into that carefully. There undoubtedly are different variations on the theme. There can be the people who just have gravitational pooling of blood from vessel laxity, but there can also be people who have let's say with May-Thurner syndrome, where the left common iliac vein is being compressed by the overlying right iliac artery. Those patients have an obstruction to flow. You can have varicose veins that are different from normal veins. They provide a big reservoir for blood to pool, especially I think for women after 1 or 2 pregnancies or more. They often will get marked dilation of the veins inside the pelvis. That can lead to all sorts of problems, but the dominant ones are low back pain, pelvic pain that gets worse as the day goes on. And because there are varicosities in and around the bladder, you get urinary urgency. People can have terrible pain with intercourse when they have this pelvic congestion syndrome. And Steve Smith, who's an interventional radiologist who has treated many, many people with this and has been studying it, finds that when you stent the area of venous compression with a May-Thurner, or you embolize the varicosities like in the ovarian vein or internal iliac distribution, those patients can get not only improvement in their pelvic pain and the bladder urgency and the pain with intercourse, but they get remote improvements in POTS, migraines, even things like irritable bowel syndrome and interstitial cystitis. So I think we need a lot more attention from the people that deal with chronic pelvic pain, especially in women, to the importance of these vascular problems and vascular dilations. It's not quite a direct answer to that question, but that, I don't think people have looked at different phenotypes of blood pooling.
And I wonder if just within that blood pooling observation about localized treatment then making whole body work better, if it's perhaps a specific case of localized inflammation, then causing systematic or systemic effects, that then if you treat that local, everything gets better. Definitely seen that some with wound healing and stuff too.
Yeah, that makes sense to me. I think the ones that we were talking about are more issues where there is something interfering with venous return to the heart. Alba, did you have something on that?
No, I became very fascinated with the changes in the lower extremities that I started to see on my low COVID patients, and my kids think I'm obsessed with legs because you can see them on my phone. But so I kind of spent a lot of time thinking about this a little bit. I think that Yeah, I think that there's changes in colors that can be different in people with long COVID or ME/CFS. There are some that are triggered by, a lot of the times they come in, oh, my doctor said I have Raynaud's, and those, there's different characteristics to the changes in color, or there's things like erythromyalgia, or there's like a different discoloration that's happening. So I think when it comes to that darkening of the pooling that we see that gets worse at minute 9 or 10 of standing, and then once you lay them down again, it goes away. I think it's pretty consistent. In one thing that I like to do is in people with more melanin, it's harder to see that change. So I look at the sole of the foot, because sometimes that area will change, and then you can see the comparison between when they're standing and when they're laying down. So that's a little trick that I use. But differences in the pooling itself, I haven't really noticed that. It's just in my experience, but it could be.
How do you look at the sole of the foot? Did they stand on a plexiglass table or something?
No, I just asked them to lift their foot at before they go up to lay down again, and take a picture of it. Yeah. And then when they're laying down, I'll just take a look after a minute, and then it's I haven't come up with a fancy contraption to look at it throughout the exam.
All right, so now I have a question that I'll bring up from the Q&A. This will be from Fiona Hart. And Fiona, if you're ready to come up and ask your question, you should be able to do so.
Sure. Hi. Yeah, I guess going back to thoracic outlet syndrome, I wondered if there's a form of it, or if it's possible if those sort of symptoms are triggered when reaching forwards rather than upwards. Is there a form of TOS like that, or is that sort of anatomically possible that it would be a cause of because of a compression, or would that if it's triggered more when reaching forward, would that indicate something else?
No, I'm glad you brought that up, because it's either arms overhead or arms extended in front of you. So among the ways we screen for this in the clinic is we ask people, how do you hold the steering wheel of the car? And if you've got thoracic outlet syndrome and your arms are extended with a drive, they don't have their arms at 10 and 2. They hold the steering wheel low because it involves less of that extension and less narrowing of the thoracic outlet. Reaching out to fiddle with the dial of the car radio. Am I dating myself by talking about reaching for the dial of the car radio? That can bring it on as well. And even if you happen to be sitting typing and you're far back from your keyboard, that's often a situation where people with thoracic outlet syndrome will get arm fatigue, but also numbness and tingling. So you're right, Fiona, it can be either arms overhead or arms extended. And also, if you're leaning back to grab something in the seat behind you, that'll bring this on as well.
Thank you.
I'm just going to kind of mention something that I've experienced with the similar, because I know I've got like thoracic outlet stuff going on. And for me, the reaching forward or doing something with my arm, when it's symptomatic, I have a spasm in the muscle just under the armpit. And it's not so much up at the top, but the up top will, if this one's spasmed and I do anything, down here is spasmed and I do anything with my arm, then when I do start reaching, then I start feeling more spasms in my neck and stuff after that, and then end up with headaches and all the other things, and the arm doesn't work as well. And so then that's one of those first things I have to do is get the muscle underneath my arm to release. And then a lot of the symptoms improve. If I don't catch it early enough, then everything goes downhill very quickly. That's like my first target one. Once I found that one, then I was like, oh, this tiny little muscle, I didn't realize it did so much. And I think it's part of the rotator cuff structure. And so it's just, it's just one of those anchor ones. So yeah, it was that was my biggest one. And that's when mine, while I have the issues with the raising the arm over the head, it's also the being forward. And I think that movement makes that muscle more likely to spasm and yank. And then once it does that, then everything else snowballs. So then it's as if I was holding my arm up for 3 minutes, even though I was just had my arm on my desk and I was typing a little bit, and then that'll be enough to trigger it. But it's just a very similar one. There's lots of angles, but anyway, that was just my comment.
You're really describing the area under the pectoralis minor muscle, which is down under here. And so when we're examining patients, we pinch the muscles, the pec major and the muscles at the back of the armpit, just to see if they're tender to light touch. And then we dig well up onto the chest wall in the middle of the armpit. And that often leads people to jump when they have thoracic outlet syndrome. It's really exquisitely tender, even though we're not really putting a lot of force into that examination maneuver. One of the procedures I believe that the surgeons use is to do a tendon release in that area lower down.
So, and I think Kat had a couple of questions. Kat, if you want to come in and ask some of yours.
Sure. I'll start with one that's probably a bit more straightforward, which is regarding the first rib. Do you see cases where high impact, high speed injuries might move that, make it, sort of bring onset these issues, like say something like a car crash or something would be equivalent?
So recurrent fractures of the clavicle because of the hypertrophy of the bone can also narrow the thoracic outlet. So probably any sort of fracture. The people who get thoracic outlet syndrome often have repetitive, are athletes with overarm use, like baseball pitchers or volleyball players and swimmers. There's probably also something about the way we sit that aggravates the thoracic outlet. So if you're hunched like this, doing a lot of desk work rather than opened up and freer, that is one of the things that the physical therapist can help people with to get them out of a posture that predisposes to compression of that area.
It's making me rethink my whole history here. Probably a lot of folks here as well.
Good. What was your other one?
Oh, goodness. There are so many. Some of the others are maybe a little bit less straightforward. So one more generally, do you know of anyone looking at kainate receptors within the glutamate system, the GRIC genes? I know this is sort of out of left field, but just in case.
I don't. Alba, are you familiar with that? I don't even know what a kainate receptor is. Sorry.
Most don't. Like honestly, when I started seeing more and more that it was probably involved, I was like, oh, please be anything but that, because the research on it is it's such a pain. But more concretely, so in terms of treatment, so if PT isn't quite sufficient, but surgery isn't yet indicated, so Botox as sort of that middle ground, does EDS play a role in that decision? I'm particularly thinking about people who have confirmed CCI-AI that possibly loosening that area might cause other problems. Is that a consideration, or do the benefits outweigh that?
I can't hear.
Do you want to tackle that?
Oh, sure. So I don't do Botox on the scaling, although I've been wanting to train on that. I have injected them before, but not regularly. I think for the scaling, there may be some consideration, but I'm just thinking about the function of the scaling muscle, right? It's kind of to pull up. So I don't know. And I do have a patient with craniocervical instability who had a removal of the scaling, so a scalenectomy. and she did okay. I do see a lot of issues with Botox in the cervical paraspinals and the occipital nerve, the occipital muscles. So I do quite a bit of Botox for migraines, and I avoid that area like the plague because inevitably a lot of my patients will describe issues with that. I mean, a lot of our patients have like that head heaviness sensation, and it gets worse, and they have to like bring their head up with their hand. So I usually avoid injecting in that area or just do like a tiny bit, but I try to stay away from that because that definitely, and some patients report other side effects from, you know, potentially their craniocervical instability being worse.
So this is where having somebody who is experienced, who is a specialist, is really important here. This isn't a spot treatment kind of thing.
Right. Yeah.
Okay, so oh, Dr. Rowe, I can't hear you again.
I think there's something wrong with my microphone. Anyway, we've had a number of patients with EDS. EDS is a risk factor for thoracic outlet syndrome. We found that it was joint hypermobility was present in 54% of the patients that we put into our study with TOS. And Dr. Erickson has talked about this in his talks at the EDS conferences about the association. But in treating those patients with Botox for their TOS, we have not found major adverse effects. But back to your question, and as Alba said, it's probably related to the function of the scalene muscle.
All
Thank
right.
you.
So our next question is going to come from one of our panelists, Denise, whenever you're ready.
Thank you. This is also about TOS. Arterial and venous compression can also result in a dilation beyond the compression. And I would assume that this might increase the risk of developing aneurysms with repeated dilation. How does that relate to EDS, HEDS, and how do you know also if in your patient population, TOS is more frequent neurogenically for people with EDS and HEDS, or arterial and venous, or combination?
Yeah, I think for the last part, Denise, there just hasn't been enough focus on this. When we did a literature review recently for our paper, we found just a couple of things that even talked about EDS in relation to thoracic outlet syndrome. It's there. We're pretty confident about that, but people haven't been paying much attention to that. Anytime you get compression of an artery, you can get what's called post-stenotic dilation of that vessel. And that can then lead to an aneurysm formation. So our vascular ultrasound technicians always look for aneurysm formation when they're doing the thoracic outlet syndrome studies. Again, nobody's really done enough work on this to determine which forms of it are more common with EDS, but I think that's an area that's very fertile ground for research and very practical for the patients who have these problems, because if you've got dilation of a vein and slow flow through a vein, you then are immediately at risk for clot formation. And so some of our patients with thoracic outlet syndrome have presented with marked swelling of the upper limb from clots and really sluggish flow through that region. So it's an important thing to look for.
It also changes like the dynamics of the flow. So I recently started to get really curious about the subclavian steal syndrome, and you know, why some of our patients have like pre-syncopal, or we've had syncopal with Dr. Rowe not that long ago. So it's, you know, so there's more to it than just the beyond just the compression at that point, there can be other.
Okay, and our next question is going to come from the Q&A, and that is Rivka. If you are ready, go right ahead.
Hi, thank you. First of all, I'm so deeply, deeply appreciative of Doctors Rowe and Azola for your amazing help all these years. And it's just heartbreaking that so many of us are still suffering. And so I'm so grateful that you have stuck with us all this time. So my question was about the NASA lean test, but I just want to say first that this thoracic outlet syndrome, discussion is so incredibly illuminating. And where would we go for more information about this? And in particular, where would we go for somebody to diagnose compression of arterial or venous compressions? And that wasn't even my question. My question was about if you use the NASA lean test, if you think it's a good tool. But I'm now more interested in where someone would go to have arterial and venous compression diagnosed. Thank you.
All right, so I'm going to get rid of my pet peeve here. It is not a NASA lean test.
You're very quiet, Dr. Rowe. We can barely hear. There you go. Oh,
Better?
you're still quiet.
Yeah, I don't know what's wrong with my system.
That's better.
Okay. My pet peeve comment about the NASA lean test is that I think it was adopted by some of my colleagues in the MECFS community, but they wanted to sort of make it seem more important. It's called a passive lean test, passive standing test in all other aspects of medicine. And I don't think we should be adopting a new terminology for it in the MECFS community. It seems like it's protesting too much. The study that they referred to as the NASA lean test was it was entitled the passive standing test, and it was done by Dr. Hyatt back in 1975. It didn't involve astronauts. It was a test that was done on several inmates of a California correctional institution. So it's a misnomer, but I probably am losing my battle to get it called the passive standing test because I think the NASA lean test is jazzier and has caught on. We use the passive standing test as our almost exclusive method of looking for orthostatic intolerance. The people in the autonomic community don't like it because it's not as likely to provoke an increase in heart rate as a tilt table test. But tilt tests are expensive. They're not available everywhere. And so if you're waiting 9 months to get a tilt test before you get diagnosed and treated, that's a long period of delay where your function will decline. So we do a 10-minute passive standing test in the clinic as part of our initial examination of all patients that come to see us for MECFS. And we're looking for, yes, the heart rate escalation of POTS, but mostly we're looking for whether or not that patient's symptoms are provoked during that 10 minutes. The average healthy person is just bored during a 10-minute standing test. And if we see symptom exacerbation, we have all we need to begin the treatment without any delay. So I think it's, while there is some theoretical criticism of the test, at a practical level, it's much, much more available to physicians anywhere. If they have a blood pressure cuff and something like a watch to measure the heart rate.
That's very helpful. And that's exactly why I was asking the question, was because I heard from people in the dysautonomia community that they don't like what you're calling the passive standing test. But I think you explained it really well, so thank you. But where does one go to get a diagnosis for arterial and venous compression?
Alba, do you want to take that?
Hi, Rivka, how are you? So there's a couple of components, right? There's has to be the suspicion, and then you can do a Ruse test to also get some evidence of it. But ultimately, the Doppler ultrasound for TOS can be another imaging that can diagnose it. It's not really owned by a specialty. I would say probably there are some vascular surgeons that specialize on this. I'm going to put a plug in for physiatrists where during our training, TOS is kind of one of those things that we're trained to look for in cases. So physiatrists are somebody that can definitely assess for that particular compression syndrome. And then usually the TOS ultrasound should be done at a specialized site because not every single ultrasound place are familiar with it. It's not something that's done regularly, so you want to make sure you're getting the study done with somebody who can actually knows how to do the study. Yeah.
And Dr. Rowe mentioned another type of compression. Thank you for that, Dr. Azola. So, but Dr. Rowe also mentioned another type of compression. I believe it was around the pelvis or the legs. What was that called again?
May-Thurner syndrome.
Yeah, it turns out there are several areas that can be compressed in the venous system, more often in people with hypermobility. But you can see compression of the left renal vein by the overlying superior mesenteric artery. That gives you something called nutcracker syndrome, where typically there is left flank pain because the kidney is engorged with venous blood that can't get back to where it's supposed to go. You get the pelvic congestion syndrome where the ovarian veins and the internal iliacs are varicose. And then, as Dr. Zola mentioned, the May-Thurner, which can also lead to collaterals filling up the pelvis. And the testing that's done for that can include a CT angiogram and venogram of the abdomen and pelvis, or some interventional radiologists who are very good at this, both at detecting it and treating it, use intravascular ultrasound to measure the degree of compression of these vessels. So there are a number of people, I would say probably most of the people who deal with this are interventional radiologists. One of the puzzles for many people is that when you look at lists of the differential diagnosis for chronic pelvic pain, if there's a paper written by an obstetrician gynecologist, it often doesn't even mention pelvic congestion syndrome. Whereas if you read the papers from the interventional radiologists, the pelvic congestion and pelvic venous insufficiency is at the top of the list. So it's probably a result of the siloing of who deals with what in medicine, but be aware that not everybody is aware of these problems, and yet they can be very easy to treat if you've got an experienced interventional person.
So you just rattled all that off so fast. Where can we go to see it written down? All the things that you just rattled off? That's my last question. Sorry to take so much time.
How about if I send Ellie a couple of papers on this, and then she can post them?
Yes, we can send that out. Also, we just put the name of the test and the CPT code in the chat to everybody for at least one of those things.
But we can't copy the chat. It's not.
Yes, you can. The 3 dots under the chat, there's a button that says Save Chat, or you can hover over the individual message and copy that one individual bubble.
No, it doesn't let us copy.
All right, I can copy the
Panelists
chat
only.
and can get it to you. I want to throw in another pelvic pain vulvodynia thing that Dr. Afrin covered when he was here, which probably is not going to be in the interventional radiology papers either, but they're thinking now for the people who have the vestibule pain, that could be a mast cell problem. And Dr. Afrin and I think another paper by another person, they've started trying to treat topically with some formulations of mast cell stabilizers with some success.
Yeah, I think those are really important observations that Larry made. He's a phenomenal clinician, and one of his papers was about the oral burning syndrome, where people just have this sense of burning in their mouths caused by mast cells and treatable quite easily with swishing and swallowing things like an antihistamine or famotidine or cromolyn. So that same kind of cutaneous burning can occur within the vaginal vault as well. And some of the women who have that, that Larry has reported, have done well with administration of one of those kinds of medications through a douche type of administration. And for many women who have those problems, it's been years that nobody's known what to do for them. And then, you know, a couple of simple treatments that are topical, directed at the mast cells, can give them tremendous relief. So I think those are really important papers to be aware of.
I can see that Dr. Azola has to leave here pretty soon. She's got a patient in clinic. And so Dr. Rowe, how long were you thinking about being able to be here too? We just actually hadn't clarified that before we started. We probably should have.
I'm good for another half hour.
Okay.
So Alba's doing the real work, and I get to just answer questions.
That's not true, but yeah, I have to go. Although this is very, very fun. I have to do my work.
Thank you so much.
Yeah, thank you for having me, and I leave you in good hands with Dr. Rowe.
Okay. I will be bringing up a person from the Q&A, and then, or actually, no, next is Michael, who's coming up with a couple of questions. So from Michael on our panel. So if you're ready to ask a couple of your questions, Michael, I mean, you've got a lot, you've got a whole lot there. So, you know, choose which ones you want to ask, and you can always come up for more later.
Thanks, Rochelle. Can you hear me?
Yes.
Great. Okay, so the first question is, what resource, message, or paper should we give to clinicians well, any clinician, but specifically if there are autonomics clinics who don't yet factor in post-exertional malaise when they see POTS patients who also are exhibiting post-exertional malaise? So, for example, they'll still get prescribed graded exercise because the clinician's only taking into account the POTS seriously, but they're missing or maybe ignoring the significance of that post-exertional malaise aspect.
Ton of information that you could take in to people. There was one paper by the Vanderbilt group that showed that there's a lot of overlap in people with POTS who have just POTS alone and POTS and ME/CFS. That came out in about 2010, I think, or 2014, somewhere in there, just showing that PEM is not simply restricted to ME/CFS. I like your question, though, because I think the focus in a lot of the POTS literature has been on exercise as the treatment. And some cardiologists have insisted that patients demonstrate adherence to an exercise program before they will offer them a medication to control their circulation. And I liken that to telling an asthmatic that you show me that you can run around the football field 4 times, then I'll think about giving you an inhaler. And any physician would regard that as madness. But yet we allow the same kind of approach to be taken with orthostatic intolerance without recognizing the potential for PEM. And so we find that controlling the circulation better enables people to exercise without PEM. And I may have mentioned this at one of the seminars before, but we had a really illustrative case of a young woman who had listened to the stuff out there about exercise with POTS. And clearly nobody is arguing against exercise as something that we want to achieve once the patient is feeling better. But this young woman had a resting heart rate of about 120 sitting in the clinic. And when she would try to go on the elliptical, her heart rate would spike up to 180 within 2 minutes, long before it should have been that high. and she would provoke a 2-day migraine. And we said to her, look, Samantha, cut it out. You've got to wait until we've got your circulation better controlled before you can tolerate this. So thankfully, along came, after about 10 years of treating her, ivabradine. And ivabradine helped lower her resting heart rate. And as she gradually increased the dose from 2.5 to 5 milligrams to 10 milligrams twice a day, by the 10 milligram point, her resting heart rate was 70. She could go on the treadmill for 40 minutes, and her peak heart rate was only 130. And so we didn't have to encourage her to exercise. Once she felt better, she just increased her activity level. And the people who would argue that exercise is all you need would say, well, then she's cured now. She doesn't need anything. Turns out that every summer when we have to get reauthorization for her ivabradine from the insurance company, she's off the medicine for 2 weeks. And what happens? Well, you guys know the answer. She gets immediately lightheaded, tachycardic, brain fogged, and PEM emerges after activity. So this issue, I think, has really been dealt with in a very blunt, clumsy way in the literature. And we do need to make sure people know that PEM is possible, whether you have ME/CFS or not.
Thank you. Okay, that's, yep, really interesting. Next question is, can hormones play a role in blood vessel laxity to the extent you might get symptoms of a compression at certain times of the month and not so much at others?
I think the first part of the question is easy to answer. You know, women are much more likely to get varicose veins than men, and especially after pregnancies. I don't know if anyone has looked at your second part of the question of, does this vary a good bit depending on the time of month? We haven't seen that as much. What we typically see in the adolescent and young adult women is that they will often be extremely fatigued right in the day or two before their period starts and throughout the menstrual period. Because that's because that's the time of the month when their blood volume is at its lowest. And in order to prevent that 1 week downturn for these people, often they have not just increased fatigue, but terrible menstrual cramping. We will put them on a continuous active birth control pill. So they have one period every 3 months. And that can be very helpful for reducing those monthly downturns in function.
Thanks. Okay. Can I do another question, Rochelle? Got time?
Yes, go ahead.
Okay, so great, thanks. Do you ever see an acquired hypermobility or EDS phenotype? So sort of a latent onset. Why do you think there can be a late onset phenotype for hypermobility? What might be driving it?
I think that's a really interesting question that hasn't been studied much, but I remember a young woman I saw as a teenager, and she had a Beighton hypermobility score.
Can you
Rowe,
turn your head to your right? Just turn it seems like when your head is over the other way, it's louder. Just turning it, yeah.
Turning to the right?
Yeah, just or to the left, yeah.
Okay. This is better?
Yeah, much better, yeah.
All right, sorry. Just thinking about that question, there's one girl that we examined when she was about 15. She still had a good muscle mass, and then she was pretty ill with her ME/CFS for quite a number of years. And about 10 years later, somebody said, no, her Beighton hypermobility score is a 6 now. And I thought, nonsense. I examined her as a teenager. There's no way it changes like that. But in fact, when we brought her back in, it had changed. So she was much more hypermobile, maybe because the muscle mass had diminished. And so she was now relying on these loose ligaments that were otherwise masked by muscles controlling the joints. But the theory has emerged as well that if the mast cells are dumping out all kinds of enzymes that break down protein, it's possible that mast cell activation can aggravate the hypermobility. That's a hypothesis that has emerged from Dr. Afrin's focus on MCAS. So I think that's a really interesting hypothesis, and it's probably true that both are both kinds of problems, both the genetic susceptibility and then some kind of acquired hypermobility are possible.
Is just a quick question about, is there any linkage temporally that you've seen with pregnancy in some of these folks? Because you get laxity of connective tissue in pregnancy as well.
Yeah, and that's often the case for people with pelvic venous insufficiency and pelvic congestion syndrome, as it was called before. The typical risk factor is several pregnancies. The Ehlers-Danlos syndrome patients are already at risk for varicose veins at an earlier point. So that is a separate risk factor for varicosities.
Okay, another one is so with compressions and then potential stenting, what are the sort of risks, complications, and when do you sort of say that's probably worth looking into versus the risks here don't seem to outweigh the benefit?
So that's probably a question that's better answered by somebody like Steve Smith from the interventional radiology community. I don't know all the data on that. I think they worry that with stents that they can move through the circulation. We've not seen that in anyone that's been treated for May-Thurner syndrome. Stenting of the compression of the left renal vein, however, is apparently technically quite difficult. So for those who have nutcracker syndrome, rather than stenting, if the symptoms are severe enough, some patients get an auto transplant of the kidney. So the kidney is taken, the vein is taken down, and the kidney is shifted down and reconnected to the main vessels a bit lower in the abdomen to relieve that venous compression and the engorgement of the kidney. That's not a small undertaking. So people need to have nice and accurate confirmation that that's the problem. But you know, somebody in interventional radiology would be very good to give a talk to this group, I would think.
Yeah,
Yes,
well,
you'll have to send us email addresses and names and an introduction to all of these wonderful people you've mentioned today that you think would make good speakers.
Yeah. Just a small finder's fee. That's all I'm asking.
Okay, all right, no problem.
so my next question, this is relatively specific to me. So, have you ever found that patients pre-diagnosis of POTS gravitate towards certain activities or sports? For example, for me, it was scuba diving because the posture was horizontal and you wear a full body compression suit and you're at depth and you're breathing air at higher partial pressures, so you've got more oxygen. Yeah, any other sports or patients, lots of patients with scuba diving turning up to your clinic?
Yeah, so that's a great point. One of the ways that people in the very
Dr. Rowe, we can barely hear you again.
I got it. This
There you
is
go.
a
That's
brand-
better.
There,
That's better.
when you face to the left, it works, and the other, it doesn't.
Oh boy, I'm not sure what is wrong with this thing, but anyway, just remind me if I'm fading out. So in the old days, the way that people would treat edema in the lower limbs they would dunk them and submerge them in a tank, so that the water pressure provided the external compression that, you know, these days we would use compression stockings to achieve. What we find is that, and we teach our trainees, if you've got a patient who comes in and they have been active in gymnastics, swimming, dance, or cheerleading, your working assumption should be that they've got hypermobility, because the hypermobility makes them better at that sport. My son was a swimmer at the North Baltimore Aquatic Club. He was 4 years behind Michael Phelps. And I was asked to see a number of the swimmers at the elite level. I've never seen a single swimmer who was not hypermobile. I think it gives them that ability to have a very whipping motion of their legs when they do a dolphin kick. And we actually, Ellie reminded me of one of the papers that we wrote a while ago, was an accumulation of all the swimmers on the US national team that I'd seen over the years, who had been sent to me because they had fatigue and what was termed inconsistent performance. So they could do a full practice on day one, but were so wiped out that they could only do a half a practice on day two. And by the third day, they couldn't, they had to rest. And I think everybody with ME/CFS recognizes that that's really PEM. But it's hard to call it chronic fatigue syndrome if you got somebody setting world records in the pool. But it turns out that by applying the principles that we had learned from seeing people like Ellie in the early 90s with ME/CFS, if you apply those principles to these athletes, we found that every one of them had orthostatic intolerance. And because they weren't that sick, many of them responded just to higher intakes of salt and fluid, or one single medication. So this was an application of the ME/CFS physiology to these athletes. Previously, athletic underperformance, as it was called, was often called overtraining syndrome. Well, none of these people were being overtrained. And overtraining syndrome usually was associated with some kind of mood disorder and treated with more psychological techniques. And many elite athletes are under a lot of pressure that way. So some of them probably improved. But the biggest change for our patients was to get them on the same kind of supportive treatment for circulation that our ME/CFS patients need. And they were able to return to full activity and very consistent practice.
All right,
Thanks.
so sorry, Michael.
Yeah, I have one, or do you want to go to the?
We've got quite a few popping up in the Q&A, so I was going to go to those. If you want to, we'll see if we have time to get to your last one. So,
Yeah, thank you very much, Dr. Rowe.
You bet.
all right, so in the Q&A, we have a person, these are coming through as anonymous ones, so that means I'll need to read them out. So with the question here is, some patients have used nicotine patches, only a small portion, the whole patch, early in the day, not at night, and have seemed to be helped. Any clinical studies that you know of that would explain this on nicotine patches?
So there have been a couple of papers with very short descriptions of the use of the nicotine patch in long COVID. I remember a story that one of the cardiologists I collaborated with, I won't name him, but Ellie knows who it is. When we were doing our early tilt table work, this guy from Texas came up and he said he was exhausted and he'd been a lifelong smoker. And every time he tried to quit smoking, he was overcome by exhaustion. And so we did a tilt test. He had the neurally mediated hypotension problem. And my colleague in cardiology said, you know, you really need to go back to your Marlboros. Nicotine happens to be a really good vasoconstrictor substance. The use of a nicotine patch makes physiologic sense that it would help some people with orthostatic intolerance. I think the trials that are going on are with very low doses so that you don't get this sort of addiction problem. But I think in the old days, a lot of people probably self-treated their orthostatic intolerance with drinking coffee, which has some vasoconstricting properties, coffee or tea throughout the day, and chain smoking. Not that we would recommend those as treatments, but it's an interesting kind of physiologic observation.
Well, and then avoiding alcohol in this population because of the opposite effect, right? The dilation.
Yeah, with alcohol, you get two things that are not helpful. One is that you're going to have flushing, so you're shifting your blood volume to the skin, and it interferes with antidiuretic hormones, so you pee more. And many of our patients will describe themselves in a humorous fashion as a cheap date, because after a half a glass of wine, they're feeling unwell as a result of worsening their orthostatic tolerance.
Yeah, and there was no buzz. A lot of people we don't get the buzz at all from the alcohol. We go straight to the hangover and the hell.
Right, right.
The aldehydes.
It broke my Scottish father's heart that I couldn't share a drink with him.
So
My Scottish grandfather as well.
Another question in the Q&A. With this subclavicular steel was mentioned earlier. I don't remember if it was you, Dr. Rowe, or Dr. Azola. But the person's asking if you can please speak more about the correlation between subclavicular steel and syndrome and thoracic outlet. I have both, but they've never been correlated before.
Yeah, I don't know how much work has been done tying them together. In the cardiology community, you'll hear about subclavian steel. So you're sort of siphoning off blood from the central circulation. I suspect, and there's some work with thoracic outlet syndrome, I think from Scandinavia, talking about how if you're plugging up the subclavian artery when your arms are overhead, if you're obstructing flow through there, the blood is still being pumped out at the same level through the heart, and so it may increase the amount of flow going up through the vessels to the brain, possibly contributing to headache. But really, in answer to your question, I don't know of work that's looked at the overlap and the correlation of those two phenomena.
Okay, so that.
I just wanted to mention that one of your recent papers is the post-Lyme treatment dysautonomia findings. And we'll drop the link to that in the chat, just to make sure that people know that you're branching out, you're trying to educate even other post-infectious and other conditions out there. But now back to our, go ahead.
Yeah. I would say to that, Ellie, that one of the things we've learned is that if you've got a substantial degree of fatigue, regardless of what other diagnosis you have, you still ought to be looking at the orthostatic intolerance as a contributor. So we did a study a long time ago looking at post-cancer treatment fatigue. So in people who had survived leukemia and lymphoma, chronic fatigue is a major influence on their overall quality of life. And we found that they were much more likely to have an increased heart rate response to standing, symptoms with standing, and often would respond to medications like we use in ME/CFS. And the problem in the oncology literature is often people with chronic fatigue after treatment, there's a suspicion that they've got survivor guilt syndrome or something like that, which is kind of not very treatable, but may not be as common as people have thought. And then we've looked at the level of fatigue in post-treatment Lyme disease, mostly with our colleagues John Alcott and his junior colleague Britt Adler. And Britt wrote that review paper that you mentioned, Ellie. She's just starting to look at the prevalence of orthostatic intolerance in her patients that meet the criteria for post-treatment Lyme disease, meaning they got treated adequately or seemingly adequately for their acute Lyme, but still have a ton of symptoms afterwards. And that's one of the arguments for looking at a grouping of post-infectious chronic conditions is that we may learn more by looking at the similarities rather than the differences among all these problems.
Do you think, as a follow-on to that observation, do you think that ultimately there's a threshold of severity that can be across any of these conditions that can be caused whether by ticks and Borrelia or by spike or by EBV or something else, that is sort of a common state of severity rather than one or another condition being a separate disease? And is it useful to think of things as levels of severity across different conditions that might put you into a compromised energy or orthostatic state? We can't hear you again. Now it's fully muted.
Okay, how about here?
Yep, yep.
Okay. I need to put this thing on a swivel. I like the way of thinking about that, looking for the common threads and the final common pathway for regardless of the particularity of the initiating infection. And we've argued this with COVID that, yeah, okay, it's different in the very beginning because of the loss of taste and smell. But by the 6-month point, all of the post-pandemic patients that meet ME/CFS criteria look like our pre-pandemic patients. EBV is a bit different in the beginning than influenza, right? You don't get a big spleen with influenza. You don't get the sore throat as much as with mono. But in the end, by 6 months, it doesn't really matter. And so maybe these infections trigger some kind of hit and run phenomenon in the body, whether it's the autonomic nervous system or the immune system response or something that we haven't uncovered. But looking for that common thread, I think, will be important, especially as we get more and more people combining folks who have different initiating triggers to their illness.
And a clue along that way, the hypoxia theory is when you, as you lose microcirculation or and blood flow and get hypoxia, you put HIF-1A into the nucleus, and that spits out ongoing chronic inflammation. And so you could have a number of pathways that would start something, and then once you get into that local hypoxia, you're sort of stuck in it. And then if that ends up being the case, then is it Navio's work with the salugenesis that then says, okay, a lot of pathways to get into that compromised state, and then here's the pathway out. And a lot of that work lines up really nicely with, what do you do to get a chronic skin wound to heal? You got to get it cleaned out and then and cleaned up, and then all of a sudden it flips over and starts healing again.
Yeah, no, I think the hunt for this final common pathway is going to be key. And, molecular mechanisms are, people's ability to disentangle those or identify them, it gets better all the time with all of the newer laboratory techniques.
So, Dr. Rowe, did you say you had to stop about now, or do you have a little more time?
I got a bit more.
Okay, so we've got a couple more questions there. I've got a question in the Q&A, and then I think Michael's got even more questions. But so question from the Q&A, is there an explanation for excessive urination and negative fluid balance in the context of ME/CFS, MCAS, orthostatic intolerance with fainting and hypermobile EDS?
I don't think we know the answer to that, but we do have some people who seem to have excessive urination. One of the treatments, if you've got that at night and getting up to pee is disrupting the quality of sleep, is a medication called desmopressin, which we in pediatrics use for kids who have enuresis, bedwetting. And desmopressin is a synthetic analog of one of our own posterior pituitary hormones, and it helps hang on to fluid in the vascular space. So you don't make as much urine at night, and you have better blood volume when you awaken in the morning. But I don't have a great answer for the people who really seem to have excessive urine output.
Okay, and then I think that Michael's got at least one more question. I mean, Michael always has lots of questions. He didn't get a chance to ask any last time, so he's been waiting.
Okay, so what research study would you perform if you had no budgetary limits or ethical limits? You can answer both of those.
Boy, I don't know. We've been so intrigued by the influence of mast cells on the overall physiology that one of the studies I think would be fascinating would be to do a randomized trial of cromolyn in all comers, regardless of whether they had any clear and clinically identifiable evidence of mast cell activation syndrome. Because the ones that we treat with cromolyn where we're directing it at some sort of mast cell symptom, often their orthostatic intolerance gets way better. And so I think that one starts getting closer to the one of the big underlying mechanisms of the illness. But they're just, I think, back to the question of what's the final common pathway of these diseases, we still don't know what to tackle. So, you know, the best study would be the one that gets at the final common pathway. I don't know how we identify that, but that would be the study to do. What we're left with in the meantime is a variety of studies looking at different aspects of the clinical phenotype. So, you know, what happens if you treat the thoracic outlet syndrome? How many people get better if you fix their vascular compression problems? But yeah, there's a long wish list of studies that need to be done. In pediatrics, Kathy Rowe from Australia, who's no relation to me, Kathy did a study of intravenous gamma globulin back in 1997, and it showed a positive benefit for adolescents with chronic fatigue syndrome. I think it's shameful that there's never been funding or interest in replicating that study, and that's over 25 years ago. That doesn't happen in other diseases. When you find a treatment that works, the studies are replicated and then become things that insurance companies have to pay for. So I think the reason it hasn't been replicated is not only the underfunding of ME/CFS research, but the complete absence of connected networks of pediatric clinicians who work on this topic. That may change with the number of clinics that are being formed to treat long COVID, but it's kind of shameful.
Yeah, at our Dr. Navio talk in January, he talked about this medication that treats African sleeping sickness, the Sumarin, right? That's the one substance or med-made substance. There are no natural made substances that can turn on this healing path again. And he can't even import it from Africa. It's not allowed to come into. So if you do get that unlimited funding, you know, that's what we want to work on. He did a trial with autism and 60% responded and had improved scores. And he's been wanting to do ME/CFS and hasn't been able to manage that. So if we have any African connections, everybody, maybe we could.
All right, good. All right, should we stop there?
If that's if you need to go on that, and then we did have somebody just ask if afterwards, if you can have a list of vascular compression problems you recommend we explore as patients, and what type of MD to go to explore this, and what kind of treatments to address them. So you don't have to answer that now. It's just like if you could do that, then we can send our follow-up email to everybody, and they can have a nice little list, because I think the talking about thoracic outlet has really sparked a lot of interest in a lot of the people. It seems like.
Well, don't forget, it's in your book, right? You have this in your book, and it's in the transcripts that we did on last year's talks. Maybe not necessarily all the diagnostic tests, though.
Right. I can send. I will introduce you, Ellie, to Steve Smith, who I think could give a very good talk on the vascular compression problems outside of TOS. He's done and I'll send a couple of his papers that you can post. He's done some really nice research. Just one of them was a Facebook group survey of women with pelvic congestion. And then he's done some really nice prospective studies of outcomes after they've fixed these venous abnormalities. And the responses are really quite striking. But yeah, I'll get that to you.
One, yeah.
Okay, well,
the correlation, what's the the comparator for those who aren't women, aren't female?
For the pelvic congestion?
Yeah.
Yeah, so males who have the same vessels affected will get like varicoceles, so a big collection of wormy vessels in the scrotum. And we've had a number of young men who have needed these embolizations as well. It's just much easier to detect in women. and I think much more prevalent. But you're right, Denise, this happens to males as well. And some of the things that these interventional radiology guys have found include interruption of the inferior vena cava. So really odd vascular malformation. So it's just an interesting area to keep focused on when people come in with the ME/CFS and similar diagnoses.
And anecdotally, it doesn't have to be somebody who you can have significant blockage without totally debilitating symptoms. I came across somebody about a few months back with long COVID that, high schooler kind of running around a little bit with track and things, and ended up, when he got tested, was incredibly congested in those vessels.
Yeah.
Okay, and Dr. Rowe,
Okay.
you said you're needing to get going, so
Well, thanks, guys. Thank you for the invitation and the great questions, and happy to come back anytime.
well, thank you, Dr. Rowe. You're always a
Thanks.
delight to have on here. We always you're so great, and you're so informative, and you so love answering questions, and it shows. So thank you so much. And to all of the attendees, we will have the recording of this available up on the Remission Biome YouTube. And so we will send you also a follow-up message with some of the links and stuff that Dr. Rowe and I had mentioned during this talk. All right, thank you.
Bye-bye.
Goodbye. Have a good afternoon, evening, everybody.
Happy Valentine's Day, everybody.
Thanks, Ellie. I'd almost
To you
forgot.
too.